Slide 1. Biochemical Assessment of Nutritional Status, Part 1. Hello everyone and welcome. Today we'll be diving into the biochemical assessment of nutritional status. I'm MS Nadeem, and I'll be guiding you through this first part of our exploration. In this session, we'll start with an introduction to biochemical assessments. Then, we'll discuss the specific uses of these measures in evaluating nutritional status. Finally, we'll delve into assessing both protein and iron status using biochemical markers. By the end of this lecture, you should be able to recognize the importance and various uses of biochemical measures in nutritional assessment. You'll also be able to discuss the methods used to assess protein status and iron status. This knowledge is crucial for effective nutritional interventions. Nutritional assessment involves a multifaceted approach. We use anthropometric methods like measuring height and weight, clinical methods involving physical examinations, and dietary methods to understand food intake. But today, we're focusing on biochemical methods, which offer a unique perspective. Biochemical methods are often considered superior because they provide more objective data compared to anthropometric, clinical, and dietary methods. These methods, also known as biomarkers, can detect nutrient deficits long before other signs appear. Some tests even reflect recent intake, complementing dietary assessments. Biochemical tests can be broadly categorized into static and functional tests. Static tests directly measure nutrients or their metabolites, like albumin, vitamins, or minerals. Functional tests, on the other hand, assess the outcome of nutrient deficiencies, such as enzyme activity or immune function. Static tests measure the concentration of a nutrient or its metabolite in blood, urine, or tissue. While they indicate nutrient levels in a specific sample, they may not always reflect overall nutritional status. It's important to remember that a single static test might not tell the whole story. Biochemical tests are valuable tools, but they're not without limitations. They should always be used in combination with dietary intake assessments, anthropometric measurements, and clinical evaluations. Non-nutritional factors, pathological conditions, medications, technical problems, and non-specificity can all influence results. Several non-nutritional factors can impact biochemical test results. Inflammation, stress, age, gender, pregnancy, and lifestyle factors like smoking and alcohol consumption can all influence nutrient levels. It's crucial to consider these factors when interpreting results. Medications can interact with nutrients, altering their absorption, metabolism, or excretion. Pathological conditions like kidney or liver disease, infections, and malabsorption syndromes can also affect nutrient metabolism and biomarker levels. Always consider a patient's medical history and medication list. Technical issues like improper sample handling and laboratory variability can lead to inaccurate results. Additionally, some biomarkers are non-specific, influenced by multiple nutrients or conditions. Some tests may also lack sensitivity, failing to detect early deficiencies. Assessing protein status is crucial for preventing, diagnosing, and treating protein energy malnutrition. We use a combination of anthropometric, biochemical, clinical, and dietary data to get a complete picture. Relying on a single indicator is rarely sufficient. Several biochemical markers can be used to assess protein status. These include creatinine excretion, albumin, nitrogen balance, and other serum proteins like transferrin, prealbumin, and retinol-binding protein. Each marker provides unique insights into protein metabolism. The creatinine height index, CHI, is a biochemical marker used to assess protein energy malnutrition and muscle mass. It compares the amount of creatinine excreted in the urine over 24 hours to an expected value based on height. Creatinine excretion is proportional to muscle mass. To calculate CHI, first measure the 24-hour urinary creatinine excretion. Then, determine the expected creatinine excretion based on standardized reference values for height, age, and sex. Finally, divide the observed value by the expected value and multiply by 100 to get a percentage. The CHI is interpreted as follows. A normal range is 80 to 120%, indicating adequate muscle mass and protein status. A CHI of 60 to 80% suggests mild protein depletion. 40 to 60% indicates moderate depletion, and below 40% signifies severe depletion. Let's look at an example. A 30-year-old male, 170.2 centimeters tall, excretes 1,200 milligrams of creatinine in 24 hours. The expected excretion for his height is 1467 mg day. The calculated CHI is 81.7%, which falls within the normal range, indicating adequate muscle mass and protein status. Nitrogen balance is the difference between nitrogen consumed and nitrogen excreted. A positive balance indicates nitrogen retention for growth or repair. A negative balance signifies nitrogen loss, potentially due to inadequate protein intake or increased breakdown. Nitrogen equilibrium means intake equals excretion. Slide 19. To measure nitrogen balance, estimate nitrogen intake by dividing protein intake in grams by 6.25. Then, measure nitrogen excretion, primarily through urinary urea nitrogen, UUN. Finally, calculate the balance using the formula. Nitrogen balance equals sign, nitrogen intake, nitrogen excretion. Let's work through a problem. A person consumes 100 g of protein per day, with 10 g of nitrogen lost as UUN and 3 g through skin and fecal losses. Nitrogen intake is 100/6.25 equals sign 16 g. Total nitrogen excretion is 10 plus 3 equals sign 13 g. The nitrogen balance is 16. 13 equals sign plus 3g, indicating a positive balance and nitrogen retention. Serum protein concentrations are useful for assessing protein status, determining risk of medical complications, and evaluating response to nutritional support. The underlying assumption is that nutritional status and liver function influence the liver's ability to synthesize proteins, affecting serum protein levels. Albumin is a key plasma protein that maintains osmotic pressure, transports molecules, and indicates nutritional status, liver function, and kidney function. It's the most abundant serum protein and a common marker in protein assessment. Low albumin levels are associated with depleted protein status and chronic conditions. Albumin is measured to assess overall health and detect kidney dysfunction through urine leakage. Normal serum albumin ranges from 3.5 to 5.0 g/100 ml, while urine albumin should be less than 30 mg day. The albumin to globulin ratio is typically greater than 1.0. During injury, infection, or surgery, the body enters a catabolic phase. In early PEM, extravascular albumin moves into the bloodstream. The body increases levels of CRP, haptoglobin, and glycoproteins to maintain normal serum concentrations despite protein and energy defects. Eventually, synthesis of albumin, prealbumin, and transferrin decreases. Serum transferrin, synthesized in the liver, binds and transports iron in the plasma. With a shorter half-life than albumin, it's considered a better indicator of changes in protein status. Low transferrin levels suggest protein energy malnutrition. Normal serum transferrin ranges from 200 to 400 mg/dl. However, transferrin's use as a nutritional index is limited by factors other than protein status. Protein-losing enteropathy and chronic infections decrease transferrin levels, while estrogen therapy, acute catabolic states, acute hepatitis, and pregnancy increase them. Prealbumin, synthesized in the liver, serves as a marker of nutritional status, inflammation, and liver function. It transports thyroxine and triiodothyronine and forms a complex with retinol-binding protein to transport vitamin A. Low prealbumin levels suggest malnutrition, chronic illness, or liver dysfunction. Like other serum proteins, prealbumin levels are affected by factors beyond protein status. Sepsis, acute catabolic states, and liver disease decrease prealbumin levels, while chronic renal failure can increase them. Always consider the broader clinical picture when interpreting prealbumin results.